All right, settle in and let's dive deep. Today we're tackling a topic that's absolutely fundamental to how your body stays alive and healthy.
Mm,
This whole intricate world of fluid balance.
yeah, it's not just about, drinking water. It's this constant dynamic process happening everywhere, from your whole body right down to your individual cells.
Exactly. And our guide for this deep dive is some foundational material, excerpts from a classic physiology textbook, Guyton and Hall.
A standard, really.
Right. Our mission today is to unpack this stuff, go really deep into the concepts, and aim to understand this system with the kind of mastery that, the elite professionals in this field have.
It's foundational for so much.
It really is. This isn't just academic. Maintaining constant body fluid volume and composition is essential for homeostasis and, well, when it goes wrong, it underlies so many common medical problems. So get ready. We're exploring the nuts and bolts and hopefully finding some surprising insights.
Okay, let's do it.
So let's start with the big picture of maintaining balance. It's actually remarkable how our bodies keep the volume and composition of fluids so incredibly constant, even though we're constantly taking things in and putting things out. How does it manage that steady state?
It really is a marvel, isn't it? At its core, maintaining that balance means that, over time, fluid intake has got to precisely equal fluid output. Simple concept, complex execution.
Okay, simple concept. Let's break down the input side first. Where does the water we gain actually come from?
Well, there are two main ways we get water daily.
The most obvious one, I guess, is ingestion, the liquids we drink, and the water that's actually in our food. Our source says under typical conditions, that's what, about 2,100 milliliters per day?
Yeah, that's the bulk of it. But then there's a cooler, less obvious source. Your body actually makes a bit of water internally.
Right, through the metabolism, oxidizing carbohydrates.
Exactly. That adds another, say, 200 milliliters per day, roughly. So you add those together, and the normal total intake is around 2,300 milliliters each day.
But that 2,300 is just an average, right? Intake can swing wildly depending on climate, habits, activity level.
Oh, absolutely. Huge variations. And that variability on the intake side means the output side has to be incredibly flexible and precise to keep things balanced. Now, fluid's also constantly being lost, but not all of that loss is regulated in the same way, which brings us to what's called insensible water loss.
Insensible meaning we don't notice it.
Pretty much. It's water we lose without being consciously aware of it. It's not sweat, it's not urine. Two main routes here. One is evaporation from the respiratory tract when we breathe.
Because we humidify the air we inhale.
Right, so even though you humidify incoming air, you still lose water vapor when you exhale. Normally that's about 300 to 400 milliliters a day. And interestingly, in cold weather, this loss actually goes up.
Up why?
Because the cold air holds less moisture, it has a lower vapor pressure, so your body has to add more water to humidify it, and you lose more when you breathe out.
Huh, okay. And the other insensible route?
That's diffusion directly through the skin. Again, this is separate from sweating. It accounts for another 300 to 400 milliliters daily, normally. Our skin, especially that outer cornified layer filled with cholesterol, is a surprisingly good barrier.
But not perfect.
Not perfect, but pretty good. But if that barrier gets seriously damaged, like with extensive burns, this insensible loss through the skin can skyrocket. We're talking maybe 10 times the normal rate, up to 3 to 5 liters per day.
Wow, 3 to 5 liters just evaporating to damaged skin.
Yeah, it really highlights how critical that skin barrier is, and it explains why severe burn patients need such massive amounts of IV fluids. So if you add up the breathing loss and the skin diffusion, normal insensible loss is around 700 milliliter a day.
That burn example really drives it home. Okay, so beyond insensible loss, we have sweat, which you said is highly variable.
Extremely variable. Normal sweat loss might be pretty low, maybe just 100 milliliters a day, something like that. But if you're doing heavy exercise or out in hot weather, it can be, well, staggering, maybe 1 to 2 liters per hour. Per hour. Okay, that would deplete your fluids incredibly fast.
Absolutely. Which is why intense thirst kicks in so powerfully in those situations. Your body's screaming for replacement.
Makes sense. And then there's water loss in feces, normally small.
Usually pretty minor, yeah, around 100 milliliters a day. But as the source points out, with severe diarrhea, this can become a massive life-threatening drain, potentially losing several liters a day if it's not corrected quickly.
Right. So insensible loss, sweat, feces. That leaves the main regulator of output.
Which brings us to the kidneys. They are the MVPs, the ultimate fine-tuners of fluid balance. They have this incredible ability to adjust the rate of urine excretion dramatically to match whatever the body has taken in or lost through all those other routes.
So they compensate for everything else.
Pretty much.
Yeah.
Depending on your hydration status, your kidneys can produce as little as, say, half a liter of really concentrated urine a day if you're dehydrated and need to conserve every drop.
Or
they can crank out as much as 20 liters of dilute urine a day if you've, chugged an enormous amount of water.
20 liters. That's incredible flexibility.
It is, and this precise kidney regulation isn't just for water. It applies just as much to electrolytes like sodium, chloride, potassium. This is what allows your body to handle huge swings in intake. For example, your sodium intake could be super low, maybe 20 milliequivalents a day, or really high, like 300, 500 millimole a day.
Yeah.
And your kidneys will adjust sodium excretion to keep your body's sodium level remarkably stable.
So the kidneys are constantly monitoring and adjusting. That's how we maintain that steady state you mentioned. Intake equals output, normally around 2,300 milliliter. But the source gives that example of prolonged heavy exercise.
Where things get pushed.
Yeah. Intake might still be around 2,300, but your total output could shoot up to over 6,600 milliliters, mostly through sweat, like you said.
And in that scenario, the kidneys clamp down hard on urine production, getting close to that half-liter minimum, trying desperately to conserve water. But even then, they can't compensate fully for massive sweat loss. You have to drink to keep up. Absolutely.
Yeah.
Okay, so we've mapped the ins and outs. Now, where does all this fluid actually live inside us?
Yeah.
You said it's not just one big sack, it's compartmentalized.
Exactly. Compartments are key. If you look at total body water, it's roughly 60% of body weight in, like, the standard 70-kilogram reference man. That works out to about 42 liters.
42 liters of water. Wow.
Yep. But that percentage, the 60%, isn't fixed. It tends to decrease a bit with age, partly because body fat percentage often increases, and fat tissue holds much less water than muscle.
Okay.
Women generally have a slightly lower percentage too, maybe closer to 50%, often linked to a higher average body fat percentage compared to men. Babies, though, are much higher, much more watery.
And we should probably remember that the 70-kilogram man is just a reference point.
Yeah.
Average weights in places like the U.S. are higher now, right? Those absolute volumes would be larger.
Good point, yes. These figures need to scale with actual body weight. Now, this 42 liters of total body water is mainly split into two major compartments. First, there's the extracellular fluid, or ECF. That's everything outside your cells. It makes up about 20% of body weight, so maybe 14 liters in our 70-kilogram guy.
And the ECF is itself divided.
Right. It has two main subcompartments. The biggest chunk is the interstitial fluid. That's the fluid bathing all the cells in your tissues, kind of the internal environment. It makes up more than 3/4 of the ECF, maybe around 11 liters.
And the rest of the ECF.
That's the plasma, the liquid, non-cellular part of your blood contained within your blood vessels. Plasma is just under 1/4 of the ECF, about 3 liters.
Okay, so ECF is outside cells, mostly interstitial fluid plus plasma. What's the second major compartment?
That's the intracellular fluid, or ICF. This is the fluid inside all the trillions of cells in your body, and it's the largest compartment by far.
How much?
About 40% of body weight, or roughly 28 liters in our 70-kilogram man, double the ECF volume. And what's fascinating is despite all the different types of cells, we have muscle cells, nerve cells, liver cells, the chemical makeup inside them, the ICF composition, is remarkably similar across the board.
Huh. Consistent internal environment for all cells. So, big picture. ECF outside, interstitial plus plasma, ICF inside. The source also mentioned a smaller category, transcellular fluid.
Ah, yes. That's kind of a specialized type of ECF. It's fluid found in specific enclosed spaces, think synovial fluid in joints, peritoneal fluid in the abdomen, pericardial fluid around the heart, intraocular fluid in the eyes, cerebrospinal fluid. It adds up to maybe 1 to 2 liters total. Important, but small volume-wise.
Got it. And then there's blood itself. We talked about plasma being part of ECF, but total blood volume?
Right. Blood volume is often considered its own functional compartment within the circulatory system. It's about 7% of body weight, so roughly 5 liters in an average adult.
And blood is a mix, like you said, plasma and cells.
Exactly. Typically, plasma, the ECF part, makes up about 60% of blood volume, and red blood cells make up the other 40%, though these percentages can vary.
And that 40% red blood cells, that's the hematocrit.
Precisely. Hematocrit is the fraction of blood volume occupied by red blood cells. Clinically, it's usually measured by spinning a blood sample in a centrifuge to pack the cells down. The measured value is slightly higher than the true percentage because a little plasma gets trapped between the packed cells, but it's a standard vital measurement.
What are normal values?
Around 0.40 or 40% for men, and slightly lower, maybe 0.36 or 36% for women.
And seeing the extremes really shows its importance.
Oh, definitely. In severe anemia, the hematocrit can plummet, maybe down to 0.10, which is barely enough to carry oxygen and sustain life. On the other end, in conditions like polycythemia, where the body overproduces red cells, it can climb way up, maybe to 0.65. That makes the blood really thick and viscous, hard to pump.
Wow, okay. So we know where the fluid is and roughly how much. Now let's get into the nitty-gritty. What is actually dissolved in these fluids? What's the chemical soup like in the ECF versus the ICF?
This is where things get really distinct, because the chemical environments outside and inside the cells are fundamentally different.
Let's start outside with the ECF plasma and interstitial fluid. You said their composition is pretty similar.
Very similar, ionically speaking, and the reason is the capillary wall separating them. It's leaky to small stuff, ions, glucose, urea. They can mostly move back and forth fairly freely, but it holds back the big molecules, especially the proteins.
So the small solutes equilibrate. What are the main ions in the ECF?
The ECF is overwhelmingly characterized by high concentrations of sodium, Na+, and chloride, Cl. Those are the dominant ions. It also has a fair amount of bicarbonate, HCO3, but it's relatively low in potassium, K+, calcium, Ca2+, magnesium, Mg2+, phosphate, and organic acids. Think salty water, basically.
Okay, high sodium, high chloride outside. What's the key difference between plasma and interstitial fluid then if the small ions are similar?
The big difference is protein. Plasma has a much higher protein concentration because those large protein molecules generally stay stuck inside the capillaries. Interstitial fluid has very little protein.
And this protein difference has consequences.
It does, due to something called the Donin effect. Plasma proteins carry a net negative charge. This negative charge tends to attract and hold slightly more positive ions, like sodium and potassium within the plasma. So cation concentration is about 2% higher in plasma. Conversely, the negative proteins slightly repel negative ions like chloride and bicarbonate, so their concentration is a tiny bit lower in plasma than in interstitial fluid.
So subtle ionic shifts due to the plasma proteins.
Exactly. Subtle but measurable. However, the source notes that for many practical purposes, clinicians often treat the ion concentrations as basically equal between plasma and interstitial fluid. The big difference remains the protein.
Okay, so ECF equals high sodium, high chloride, low potassium, low protein, except plasma. Now, contrast that with the fluid inside the cells, the ICF. The cell membrane is the barrier here, right? More selective than the capillary.
Much more selective. It's highly permeable to water, but it tightly controls the movement of most ions. And because of this selective barrier, the chemical world inside the cell is dramatically different.
How different?
It's almost the mirror image of the ECF for the major ions. ICF is low in sodium, low in chloride, and has virtually no free calcium.
Okay, opposite of ECF, so what's it high in?
It's rich in potassium, K+, and phosphate. Those are the dominant intracellular ions. It also has moderate amounts of magnesium and sulfate. And critically, the ICF has a very high protein content, roughly 4 times higher than even plasma, because cells make and use most of their proteins internally.
That's a massive difference. High Na plus K-dal outside, a K plus K-dal, phosphate, protein inside. It really underscores the work the cell membrane pumps, like the sodium-potassium pump, must be doing constantly to maintain those gradients.
Absolutely essential work. And besides the ions and proteins, the source also lists other things dissolved, especially in plasma nutrients like glucose, fats, waste products like urea, creatinine, bilirubin, a whole complex mixture.
Right, and all these dissolved particles, ion, proteins, glucose, etc., contribute to a crucial property. Osmolarity?
Or is it osmolality? Good question. They're similar concepts. Osmolarity is the concentration of osmotically active particles per liter of solution. Osmolality is per kilogram of water. Because body fluids are mostly water and quite dilute, the values are very close, and clinically, people often use osmolarity.
And this osmolarity is what drives water movement.
Exactly. It determines the osmotic pressure, the potential force that pulls water across a semi-permeable membrane, like the cell membrane.
How strong is that force?
Potentially enormous. The source uses the example of both 0.9% saline, which is roughly isosmotic with body fluids. Its calculated osmolarity is around 308 milliosmoles per liter, osmol. Using Van Hoff's law, the potential osmotic pressure this could generate against pure water is almost 6,000 millimeters of mercury.
6,000 millimeter Hg. That's huge. Like atmospheric pressure is only 760.
It's a massive potential force. Now, the source also mentions the osmotic coefficient. Because ions in solution interact electrically, they don't behave completely independently, which slightly reduces their effective osmotic activity. For AACl, the coefficient is about 0.93, so the actual effective osmolarity of 0.9% saline is closer to 286 milligauss/ml. This correction isn't always used in quick calculations, but it's the more precise value.
Okay, so there's a slight correction, but the main point is the total concentration of all these particles.
Yes, and the critical thing is that under normal conditions, the total osmolarity of all three main fluid compartments, plasma, interstitial fluid, and intracellular fluid, is kept remarkably constant and equal, right around 300 mg/ml, or the corrected value around 282 millisem.
All three are the same concentration.
Almost exactly. Plasma is technically very slightly higher, maybe by 1 millicomel, mostly due to the osmotic effect of those plasma proteins we talked about. That tiny difference contributes about 20 millimeter Hg of osmotic pressure holding fluid in the capillaries. But comparing ECF and ICF across the cell membrane, the osmolarity is essentially identical.
And what particles contribute most to that total osmolarity?
In the ECF, it's primarily sodium and its associated anions, mainly chloride and bicarbonate. In the ICF, it's mainly potassium and its associated anions, largely phosphates and proteins.
So different ingredients, but the total concentration is the same everywhere, around 282, 300 ml. And this equality is maintained by water moving freely.
Precisely. Any difference in osmolarity creates that huge potential osmotic pressure, and water moves instantly across cell membranes to eliminate the difference. It's a fundamental principle of fluid balance.
Okay, that makes sense. So we know the compartments, the volumes, the chemical makeup, the osmolarity. But how do scientists or doctors actually measure the volume of, say, the ECF or the ICF in a living person? You can't just drain it out.
Right, you definitely can't do that. They use a clever technique called the indicator-dilution principle.
Indicator-dilution, how does that work?
The basic idea is pretty elegant. You take a known amount of a substance, the indicator, and you inject it into the body. The key is choosing an indicator that you know will spread out evenly only within the specific fluid compartment you want to measure.
Okay, like a tracer dye for just one pool of water.
Exactly. You let it mix thoroughly within that compartment, then you take a sample of fluid from that compartment and measure the indicator's concentration, how much it got diluted.
And if you know how much you put in and how diluted it got, you can figure out the volume.
Precisely. It's based on conservation of mass. The total mass of indicator injected equals the final concentration multiplied by the volume of the compartment it dissolved in, so you rearrange that. Volume inject, mass injected, final concentration.
Makes sense. The source gives an example, right? Like injecting 1 milliliter of a 10 millibulary dye.
Yeah, so you inject 10 milligrams total. If you measure the final concentration in the compartment as, say, 0.01 millijoule, then the volume must be 10 milligram, 0.01 millijoule all equals 1,000 milliliter.
Simple math. But the trick must be finding the right indicator.
That's the crucial part. A good indicator has to meet strict criteria. It must disperse evenly throughout the compartment. It must stay only in that compartment, not leak into others. And it shouldn't be metabolized or excreted during the mixing time, or at least you need to be able to account for any loss.
Okay, so what substances actually work for the different compartments? The source listed some.
It did. To measure total body water, you need something that goes everywhere water goes, inside and outside cells. So you use things like radioactive water using isotopes like tritium-3H or deuterium-2H, or a lipid-soluble substance called antipyrine. These mix throughout all body water within a few hours.
Okay. What about extracellular fluid volume, something that stays outside cells?
Right. You need substances that cross capillaries easily but don't readily enter cells. Examples include radioactive sodium or chloride ions, or larger molecules like radioactive iothalamate, thiosulfate, or inulin. These generally mix throughout the ECF, plasma, and interstitial fluid within about 30 to 60 minutes.
The source mentioned these might leak slightly into cells, so it's sometimes called sodium space or inulin space.
Yes, it's an approximation because the barrier isn't absolutely perfect for all these, but it gives a good estimate of ECF volume.
And for plasma volume specifically, you need something trapped in the blood vessels.
Exactly, something that doesn't easily cross the capillary walls. The classic indicators are substances that bind tightly to plasma albumin, like radioactive iodine-labeled albumin, 125I albumin, or a dye called Evans blue, T1824. These stay confined to the plasma long enough for measurement.
Okay, so we can measure total body water, ECF volume, and plasma volume directly using these indicators. What about the other compartments, like ICF and interstitial fluid?
Those are usually calculated indirectly. There's no good indicator you can inject that only goes into the ICF or only into the interstitial space.
So how do you get their volumes?
By subtraction. Intracellular volume, ICF, is simply total body water minus extracellular fluid volume.
Makes sense. Total minus the outside part equals the inside part.
Yeah. Yep. And interstitial fluid volume is extracellular fluid volume minus plasma volume.
Okay, ECF minus the blood plasma part leaves the fluid bathing the cells. Clever. And what about total blood volume?
You can calculate blood volume if you've measured plasma volume and you know the hematocrit. Since plasma is the non-cell part, blood volume, plasma volume, 1 hematocrit.
Can you walk through that calculation?
Sure. If you measure plasma volume as 3 liters and the hematocrit is 0.40, meaning 40% cells, 60% plasma, then blood volume is 3L, 1.40, 1.60, 0.60 equals 5 liters.
Got it. Or you could measure directly.
Yes. The other way is to label the red blood cells themselves, maybe with radioactive chromium, 51Cr. Inject those labeled cells, let them mix in the circulation, and then use the indicator-dilution principle on the red cells to determine total red cell volume. From that and the hematocrit, you can calculate total blood volume.
Okay, so a combination of direct measurements and calculations lets us quantify all these compartments. That's essential for understanding what happens next, how fluid actually moves between them.
Right. What forces drive that constant exchange?
Well, the source mentions 2 different sets of forces, depending on which barrier we're crossing.
Okay.
For fluid movement within the ECF, that is, between the plasma inside the capillaries and the surrounding interstitial fluid, it's mainly governed by the balance of hydrostatic pressures and colloid osmotic pressures across the capillary wall. Those are the classic Starling forces.
Right. The push of blood pressure versus the pull of plasma proteins. We'll probably dive deeper into those when talking about edema later.
Exactly. But for the movement of fluid between the ECF and the ICF, crossing the cell membrane, the dominant force is different. It's mainly driven by osmotic effects, specifically differences in the concentration of small solutes, like sodium, chloride, and other electrolytes.
And why osmosis here?
Because, as we established, the cell membrane is highly permeable to water, but relatively impermeable to most of those key ions, like Na+ and K+. So if there's a difference in the total solute concentration across the membrane, water moves rapidly by osmosis to equalize it.
Water follows the solutes.
Precisely. This rapid water movement is what normally keeps the intracellular fluid osmotically balanced, or isotonic, with the extracellular fluid.
So if you suddenly dump a load of salt, NaCl, into the ECF, making it more concentrated,
water gets pulled out of the cells into the ECF to dilute it back down until the concentrations match.
and if you somehow dilute the ECF, say by drinking tons of pure water,
Water moves into the cells, causing them to swell, again, until the concentrations equalize.
this is where those terms tonicity and osmoticity become really important and sometimes a bit confusing.
Okay, let's clarify them. Tonicity.
Tonicity specifically refers to the effect a solution has on cell volume. And critically, it depends only on the concentration of impermeant solutes. The ones that cannot easily cross the cell membrane, like sodium and chloride, are effectively impermeant for the cell.
So tonicity predicts swelling or shrinking.
Exactly. An isotonic solution has the same concentration of impermeant solutes as normal body fluids, around that 282 millismol effective osmolarity. If you put cells in it, their volume won't change. Think 0.9% saline or 5% glucose solution, because the glucose gets quickly taken up and metabolized by cells, leaving just water. These are safe for IV infusion.
Okay, hypotonic.
Hypotonic solutions have a lower concentration of impermeant solutes. Water moves into cells, causing them to swell.
In hypertonic.
Hypertonic solutions have a higher concentration of impermeant solutes. They pull water out of cells, causing them to shrink. Figure 25 in the source illustrates this nicely.
Got it. Tonicity effect on cell volume based on impermeant stuff. How is that different from osmoticity?
Osmoticity, isosmotic, hyperosmotic, hypoosmotic, simply compares the total osmolarity of a solution, including both permeant and impermeant solutes, to normal body fluid osmolarity, 300 millismol or 282 corrected.
Regardless of whether the solutes can cross the membrane?
Right. For example, a strong urea solution might be hyperosmotic compared to cells. But because urea can eventually permeate the cell membrane, it doesn't exert a sustained osmotic pull. It causes only a transient shift in water, maybe temporary shrinkage, but doesn't have a lasting effect on cell volume like hypertonic saline would. So it's hyperosmotic, but effectively isotonic, or even hypotonic in the long run. Tonicity is the more relevant concept for predicting steady-state cell volume changes.
Okay, that distinction is key. Tonicity rules cell volume. And how fast does water move to reach this osmotic equilibrium across the cell membrane?
Incredibly fast. The source says within seconds or minutes. Water permeability of the cell membrane is very high.
But if you drink a lot of water, it takes longer for the whole body to adjust.
Right. While osmosis across any individual cell membrane is rapid, achieving equilibrium throughout the entire body takes a bit longer, maybe around 30 minutes. The ingested water needs to be absorbed from the gut, circulated by the blood to all the tissues, and then equilibrate across all the cell membranes.
So near-instant local adjustment, but whole-body adjustment takes time for distribution.
Okay, this lays the groundwork perfectly for understanding what happens in abnormal situations. How do things like dehydration or getting different IV fluids actually affect the volumes and osmolarities of the ECF and ICF?
This is where applying those principles we just discussed becomes really powerful for predicting outcomes. The source highlights two fundamentals to keep in mind when analyzing these scenarios.
What are they?
First, water moves rapidly across cell membranes, so ECF and ICF osmolarities are always kept nearly equal except for maybe very brief moments. Second, cell membranes are largely impermeable to the major players like sodium and chloride. This means that the total number of osmoles of these key solutes within the ECF and ICF generally stays constant unless you are actively adding or removing those specific solutes from the ECF.
Okay, osmolarity stays equal and the main solutes stay put in their compartments. Got it.
So let's use those rules to trace what happens when you add different types of saline solution to the ECF, like with an IV drip. Figure 25-6 helps visualize this. What if you add isotonic saline, say 0.9% ACL?
Isotonic saline has roughly the same osmolarity as the ECF and ICF. The added sodium and chloride mostly stay in the ECF because they don't easily enter cells. Since the osmolarity hasn't changed, there's no osmotic drive for water to shift between ECF and ICF. The result? Only the ECF volume increases by the amount you infused. ICF volume and the osmolarity of both compartments remain essentially unchanged.
Simple expansion of the ECF. Oh, okay, what about hypertonic saline? Something saltier than body fluids, like 3% ACL.
Right. You add this concentrated solution to the ECF. This immediately increases the ECF's osmolarity. Now, the ECF is more concentrated than the ICF. Because the extra NaCl can't easily get into the cells, what happens?
Water gets pulled out of the cells by osmosis.
Exactly. Water shifts from the ICF to the ECF to try and dilute the ECF back down towards equilibrium. So the final outcome is ECF volume increases, and it increases by more than the volume you actually infuse because you've pulled water out of the cells. Consequently, the ICF volume decreases, and the osmolarity ends up higher in both compartments, balanced at a new elevated level.
So ECF expands a lot, ICF shrinks, everyone gets more concentrated. Now the opposite, hypotonic saline. Less salty than body fluids, maybe 0.45% ACL.
You add this dilute solution to the ECF that decreases the ECF osmolarity, making it less concentrated than the ICF.
So water moves into the cells.
Correct. Water moves osmotically from the now more dilute ECF into the relatively more concentrated ICF, causing the cells to swell. The result is an increase in volume in both the ICF and the ECF compartments because you added volume initially, but the ICF volume typically increases more proportionally because of the water shift, and the final osmolarity in both compartments is lower than the starting point.
Okay, that makes sense. Volume increases everywhere, cells swell, everything gets diluted. The source actually walks through a detailed calculation for the hypertonic saline infusion, right?
Yes, and it's really instructive to see the numbers. They take a 70-kilogram patient, assume initial ECF is 14L, ICF is 28L, total 42L, and initial osmolarity is 280 millismol.
Okay, baseline established.
Step 1. Calculate initial total osmoles in each compartment, ECF. 14L 280 millismol equals 840 millism. ICF 28L 280 millismol equals 840 millism. Total body osmoles equals 760 millism.
Got it. Step 2. Infuse the hypertonic saline. They use 2 liters of 3.0% ACL.
Right.
First, figure out how many osmoles that adds. 3.0% ACL is 30 grams slide out. The molecular weight of the NCL is about 58.5 DML, or 1,026 millisl.
Okay, so 2 liters of that adds.
2L 1026 millisml, it is 2052 millism. These are added directly to the ECF.
So instantaneously before water shifts. ECF volume becomes 14 plus 2 plus 16L. ECF osmoles become 3920 plus 2052 plus 3972 L's. The instantaneous ECF concentration would be 572 L's, and 16L is 3 number forward site. SCF is momentarily unchanged. 28L, 7A for 40 millism, 280 millism. Total volume is now 44L. Total osmoles 117760 plus 2052 plus 2052 equals on 307, 12 millism.
Big difference in concentration there, 373 versus 280, so water has to move. Step 3, after osmotic equilibrium.
Water shifts until the osmolarity is equal everywhere. The new equilibrium osmolarity will be the new total osmolarity divided by the new total volume, 1,312 millism, 44 L's on 313.9 millism.
Okay, so both compartments will end up at roughly 314 millism. Now find the final volumes.
Yes, remember the original osmoles tend to stay in their compartments. So new ICF volume, initial ICF osmoles, final osmolarity, third man 72 millism, 313.9 millism at 24.9 LA.
So the ICF grew from 14 L's up to 19 L.
And the ECF grew from 14 L's up to 19 L? Exactly. So adding just 2 liters of hypertonic saline resulted in the ECF volume increasing by over 5 liters, while the ICF volume decreased by almost 3 liters, and the osmolarity of the entire system shot up from 280 to nearly 314 millilsml.
Wow. That calculation, while a bit involved, perfectly illustrates the massive fluid shifts driven purely by adding impermanent solutes to the ECF. Understanding that is really key.
Absolutely critical.
The source also briefly mentions common IV solutions like 5% glucose. You said it's isotonic initially?
Yes, 5% glucose solution has an osmolarity close to body fluids, so it doesn't cause major osmotic shifts immediately upon infusion. But the key difference from saline is that glucose is rapidly metabolized by cells.
Ah, so the glucose disappears, effectively leaving behind.
Free water. This water then dilutes the ECF, lowering its osmolarity. The excess water is normally just excreted by the kidneys, but this property means 5% glucose can sometimes be used cautiously to treat dehydration. The free water it provides helps lower the elevated ECF osmolarity seen in dehydration, allowing some water to move back into shrunken cells.
Okay, interesting therapeutic use based on metabolism. Now, building on all this, let's pivot to the clinic and talk about major problems involving fluid balance, particularly sodium abnormalities, since plasma sodium is our best readily available indicator of ECF osmolarity.
Right, and hyponatremia, meaning low plasma sodium, typically below 142 mmQL or so, is incredibly common. The source notes it might affect 15–25% of hospitalized patients.
That common. Wow. What causes it?
Generally falls into 2 main categories, as outlined in Table 25-4 in the source material. Scenario 1. You lose more sodium than water. This leads to hyponatremia plus dehydration, meaning decreased ECF volume. Think causes like severe diarrhea or vomiting, overuse of certain diuretics, specific kidney diseases where you waste sodium, or Addison disease where you lack aldosterone needed for sodium retention.
Okay, sodium loss,
Yes.
water loss. What's the other scenario?
Scenario 2. You retain too much water, which dilutes the sodium. This causes hyponatremia with overhydration, meaning increased ECF and usually ICF volume too. This is often due to excessive secretion of antidiuretic hormone, ADH, which makes the kidneys hang on to too much water. A classic cause is SIADH syndrome of inappropriate ADH secretion, which can be triggered by various things, like certain lung diseases or tumors.
So either losing salt or gaining too much water. What's the main danger of hyponatremia?
The critical danger, especially if it develops rapidly, is cell swelling due to osmosis. When the ECF sodium and osmolarity plummet quickly, water rushes into the relatively more concentrated cells, and the organ most vulnerable to this swelling is the brain.
Brain edema. Why is that so dangerous?
Because the brain is encased in the rigid skull, it can only swell by about 10% before pressures rise dangerously, potentially compressing vital structures. This can lead to neurological symptoms ranging from headache, nausea and lethargy to disorientation, seizures, coma, brain herniation, and ultimately death. A rapid drop below 115–120 millimole is a true medical emergency.
That sounds terrifying. Does the brain have any defense if it happens slowly?
It does, remarkably. If hyponatremia develops gradually, over days, brain cells can adapt. They actively transport solutes, not just ions like Na plus Cl, K plus A, but also organic molecules like glutamate out of the cell into the ECF. This lowers the cell's internal osmolarity, reducing the osmotic gradient and lessening the amount of water that flows in. It attenuates the swelling.
That's an amazing adaptation. But wait, does that adaptation create its own problem if you then try to fix the hyponatremia?
Precisely. That's the hidden danger. If you correct chronic hyponatremia, where the brain cells have adapted by shedding solutes too rapidly with, say, hypertonic saline...
So you make the ECF super concentrated again really fast.
Exactly. The ECF osmolarity shoots up, but the brain cells, having lost their internal solutes, can't adapt back quickly enough. Water is then rapidly sucked out of these relatively solute-depleted brain cells.
Causing them to shrink violently.
Yes, and this rapid osmotic shrinkage can cause severe damage, specifically a condition called osmotic demyelination syndrome, where the protective myelin sheath around nerve fibers is damaged. This can lead to devastating, often permanent, neurological injury.
So correcting it too fast is just as dangerous as the hyponatremia itself if it was chronic.
Absolutely. That's why the guidelines emphasize slow correction for chronic hyponatremia. The source quotes limits like raising the plasma sodium by no more than 10-12 millimole in the first 24 hours and less than 18 millimole over 48 hours. You have to give the brain cells time to gradually recapture the solutes they lost. Understanding the time course acute versus chronic is critical for safe treatment.
Wow. Okay, what about the opposite problem? Hypernatremia. High plasma sodium, meaning high osmolarity. Is that common?
Less common than exponatremia, but still very serious when it occurs. It also falls into two main categories based on Table 25-4. First, you can have water loss exceeding sodium loss. This leads to hypernatremia with dehydration, decreased ECF and ICF volume.
What causes that kind of water loss?
The classic cause is an inability to produce or respond to ADH, the hormone that tells kidneys to conserve water. If you can't make ADH, central diabetes insipidus, or your kidneys ignore it, nephrogenic diabetes insipidus, you lose massive amounts of water in dilute urine. More commonly, though, it's just simple dehydration, not drinking enough water to replace normal losses, especially during heavy sweating or illness.
Okay, water loss driven. What's the other cause?
Excess sodium gain or sodium retention exceeding water retention. This leads to hypernatremia with overhydration, meaning increased ECF volume but decreased ICF volume as water shifts out of cells. A potential cause is excessive aldosterone, which makes kidneys retain sodium. However, this usually doesn't cause severe hypernatremia because the sodium retention also tends to stimulate thirst and ADH release, leading to some compensatory water retention.
So usually the body tries to protect itself from hypernatremia.
Yes, the key defenses are intense thirst, which hypernatremia strongly stimulates, and ADH release, prompting water conservation by the kidneys. Severe symptoms usually only occur if these mechanisms fail or can't be acted upon, like in patients with impaired thirst sensation due to hypothalamic problems, or individuals who can't access water freely, such as infants or confused elderly patients, or in severe diabetes insipidus.
And similar to hyponatremia, if hypernatremia has been chronic, does correction need to be slow?
Yes, for the same reason, but in reverse. Brain cells also adapt to chronic hypernatremia, but they do it by increasing their intracellular concentration of solutes to prevent excessive shrinkage. If you then rapidly correct the hypernatremia by giving hypoosmotic fluids, like 5% glucose in water, water will rush into these solute-loaded brain cells faster than they can get rid of the extra solutes, potentially causing dangerous swelling and osmotic injury. So slow correction is key for chronic hypernatremia too.
So for both low and high sodium, the rate of change and the duration are just as critical as the absolute number because of these osmotic forces and cellular adaptations, especially in the brain.
Absolutely. It's all about osmotic balance and the time it takes for cells to adjust.
Okay, let's shift focus now to a very visible consequence of fluid imbalance. Edema. That's the swelling caused by excess fluid in the tissues, right?
That's right. Edema is the accumulation of excess fluid. Most commonly, we think of it as being in the extracellular spaces, specifically the interstitium, but it can also involve fluid accumulation inside the cell's intracellular edema.
What causes intracellular edema?
Well, we just talked about one cause, rapid hyponatremia, where water rushes into cells osmotically. Another major cause is depressed tissue metabolism. If tissues aren't getting enough blood flow or nutrients, their metabolic activity slows down, and the ion pumps in the cell membranes start to fail, particularly the sodium-potassium pump.
So sodium leaks in and can't be pumped out.
Exactly. Sodium accumulates inside the cell, water follows by osmosis, and the cell swells. This can happen in tissues that are poorly perfused or ischemic, and it can be a prelude to cell death. Lack of adequate nutrition can also impair pump function over time.
Any other causes?
Inflammation is another one. Inflammatory processes often increase the permeability of cell membranes, allowing ions like sodium to leak in more easily, again leading to osmotic water entry and cell swelling.
Okay, so intracellular edema is linked to osmotic imbalance or cell injury dysfunction. What about the more common extracellular edema, the kind that makes ankles swell?
Right, that's excess fluid accumulation in the extracellular space,
Yeah.
primarily the interstitial fluid compartment. The source boils it down to two fundamental underlying causes.
Only two.
Two main mechanisms. Either there's abnormal excessive leakage of fluid out of the capillaries into the interstitial space, or the lymphatic system fails to adequately return the fluid and protein that normally leaks out back into the circulation. That second one is called lymphedema.
But the most common cause is the leaky capillaries.
Yes, by far the most frequent clinical cause is excessive capillary fluid filtration. Too much fluid moving from the plasma into the interstitium.
And what determines that filtration rate? You mentioned Starling forces earlier.
Exactly. The balance of forces across the capillary wall, remember the equation, filtration,
Huh?
PC pis T plus MIMF.
Let's break that down again.
PFF, capillary filtration coefficient. It reflects both the permeability of the capillary wall, how leaky it is, and the total surface area available for filtration. Capillary hydrostatic pressure. That's the blood pressure inside the capillary, pushing fluid out. Interstitial fluid hydrostatic pressure, the pressure in the fluid surrounding the capillary, pushing fluid in or opposing filtration. It's normally slightly negative.
What are you saying?
Plasma colloid osmotic pressure or oncotic pressure. This is the osmotic pull generated by the plasma proteins, mostly albumin, that can't easily cross the capillary wall. It pulls fluid into the capillary.
And PEEF?
Interstitial fluid colloid osmotic pressure, the osmotic pull from the small amount of protein that does leak into the interstitium. It pulls fluid slightly out of the capillary.
Okay, so edema happens when filtration out exceeds return. Based on that equation, what factors would increase filtration and potentially cause edema?
Well, you could increase the filtration coefficient, KFF, meaning the capillaries become leakier or more of them open up. You could increase the capillary hydrostatic pressure, PC, more force pushing fluid out. Or you could decrease the plasma colloid osmotic pressure, less force pulling fluid back in. An increase in interstitial protein concentration, would also favor filtration, but that's usually linked to the lymphatic issue.
So leakier capillaries, higher capillary pressure, or lower plasma protein concentration are the main culprits for excessive filtration edema. Now tell us more about the other cause, lymphedema.
Lymphedema is specifically about the failure of the lymphatic system. Normally, the lymphatics act like a drainage system for the interstitium. They collect the excess filtered fluid and, very importantly, the small amount of protein that inevitably leaks out of the capillaries and return both back to the bloodstream.
So if the lymphatics are blocked or damaged,
then fluid starts to accumulate, but critically, the protein also builds up in the interstitial fluid. This increased protein concentration raises the interstitial fluid colloid osmotic pressure.
so the protein buildup itself pulls more water out of the capillary.
Exactly. It creates an osmotic gradient favoring filtration, making the edema worse. It becomes a vicious cycle.
What causes the lymphatic failure?
It can be due to physical blockage or loss damage of lymphatic vessels. The source gives some dramatic examples, like infection with filarial nematodes, parasitic worms that block lymph channels, causing the massive swelling called elephantiasis, often in the legs or scrotum. Other causes include cancer infiltrating or compressing lymph nodes, surgical removal of lymph nodes, like during mastectomy for breast cancer, which can lead to arm lymphedema, radiation therapy damaging lymphatics, trauma, or even congenital problems where the lymphatic system didn't develop properly.
Okay. The source provides a really helpful summary categorizing all the causes of extracellular edema based on those underlying mechanisms. Can we run through those?
Sure. It's a great framework. Category 1 is increased capillary pressure, PC. This is a huge one.
What raises capillary pressure?
It can be systemic, like when the kidneys retain too much salt and water due to kidney failure or excess mineralocorticoid hormones, like aldosterone, which expands blood volume. Or it can be due to high venous pressure, which backs up into the capillaries. This happens classically in heart failure. Or if there's a venous obstruction, like a blood clot, or if the venous pumps, the muscles squeezing veins in your legs when you walk, aren't working due to paralysis, immobilization, or faulty vein valves.
Anything else raise PC?
Yes. Decreased resistance in the arterioles feeding the capillaries can also do it, letting more pressure through. This can happen with excessive body heat, failure of sympathetic nerve control, or certain vasodilator drugs.
Okay, that's category 1. What's 2?
Category 2 is decreased plasma proteins, at C, meaning less osmotic pull holding fluid in the capillaries.
How do plasma proteins get low?
2 main ways. Either you lose them or you don't make enough. You can lose large amounts of protein in the urine if the kidney's filters, glomeruli, are damaged. That's called nephrotic syndrome. You can also lose protein from large areas of damaged skin, like in severe burns or extensive wounds.
And failure to produce them.
That primarily points to the liver, which makes most plasma proteins, especially albumin. So severe liver disease, like cirrhosis, leads to low plasma protein production. Severe protein malnutrition also causes it.
Got it. Category 3.
Category 3 is increased capillary permeability, KF. The capillaries just become leakier than normal.
What makes capillaries leaky?
Inflammation is a major cause. Immune reactions release substances like histamine that increase permeability. Toxins, bacterial infections, certain vitamin deficiencies, like vitamin C, needed for capillary wall integrity, prolonged lack of oxygen, ischemia, and burns all damage capillary walls and make them leak excess fluid and protein.
Okay. And the final category, IV.
That's blockage of lymph return, which is lymphedema, caused by the factors we already discussed. Cancer, infections like filariasis, surgery removing lymph nodes, congenital issues.
That's a really comprehensive list. It shows how diverse conditions like heart failure, kidney disease, liver disease, infections, burns, and even standing still too long can all lead to edema through one or more of these mechanisms. The source gave specific clinical examples too, right?
Yes, like heart failure. It's a classic example hidden multiple mechanisms. The failing heart causes blood to back up, raising venous and capillary pressure, PC. The reduced blood flow to the kidneys also makes them retain salt and water, increasing ECF volume further. Plus, the body activates hormonal systems like renin-angiotensin-aldosterone, and in late stages, ADH, worsening fluid retention. It all adds up to generalized edema.
And left-sided failure can cause pulmonary edema.
Exactly, because pressure backs up specifically into the lung capillaries, forcing fluid into the air sacs. Very dangerous.
Another example was decreased kidney excretion.
Right. If the kidneys simply can't get rid of enough salt and water, ECF volume increases directly, leading to widespread edema and often hypertension because of the increased blood volume. Acute glomerulonephritis and inflammatory kidney disease is given as an example.
And decreased plasma proteins.
The examples were nephrotic syndrome, losing protein via kidneys, and cirrhosis, liver not making enough protein. Both lead to low plasma oncotic pressure, increased filtration, and edema. Cirrhosis often has the added problem of scarring that compresses portal veins in the liver, raising capillary pressure in the gut, and contributing to a site's massive fluid accumulation in the abdominal cavity.
Ascites is specifically fluid in the abdomen.
Yes, and effusion in the peritoneal cavity, often containing significant amounts of protein that leaked out due to the high pressure and sometimes leaky capillaries in the abdominal circulation. It can accumulate many liters.
So edema is often a signpost pointing back to a major problem with the heart, kidneys, liver, capillary integrity, or lymphatics. But given all these potential causes, it's interesting the source says serious edema usually requires a significant abnormality. We don't all swell up easily. Why is that? Are there defenses?
Oh, absolutely. The body has remarkably effective safety factors that actively resist edema formation. Normally, you have to push the system quite hard before you see significant swelling. The source highlights 3 major safety mechanisms, shown nicely in Figure 25-8.
Okay, what's the first line of defense?
The first is the low compliance of the interstitium when the interstitial pressure, PIF, is negative. This provides about a 3 millimeter Hg safety factor.
Low compliance, meaning it resists stretching, and negative pressure.
Right. Normally, in loose tissues, the interstitial fluid pressure is actually slightly below atmospheric pressure, around Garangolitis 3 millimeter Hg. It's like a slight suction holding things together. Now, low compliance in this negative range means that even a small increase in interstitial fluid volume causes a relatively large increase in the interstitial fluid pressure.
How does that help?
Because PIF is a force that opposes further filtration from the capillaries. Remember, it's subtracted in the Starling equation, PC. So as soon as a little extra fluid starts to filter out, PIF rises quickly from -3 towards 0, pushing back against more filtration. This effect alone means capillary pressure has to rise by about 3 millimeter Hg just to overcome this initial resistance before fluid really starts accumulating significantly.
What makes the interstitium behave like that?
A key component is the interstitial gel, this complex messwork of proteoglycans and collagen fibers filling the space between cells. In the normal negative pressure state, most of the interstitial fluid is trapped within this gel structure, like water and gelatin. There aren't large pockets of free fluid. The gel network itself provides elastic resistance to expansion.
And this changes when edema develops.
Yes. When PIF rises above 0 and becomes positive, the gel structure gets disrupted, pushed apart. Large rivulets and pockets of free fluid form. At this point, the tissue compliance becomes very high. Large amounts of fluid can pour in with only small further increases in pressure. This free fluid is what allows you to make a pit when you press on edematous tissue pitting edema. The gel normally prevents that easy fluid movement.
So the gel provides low compliance normally, acting as the first buffer. What's the second safety factor?
The second is the ability of the lymphatic system to increase its flow rate dramatically. This contributes about a 7 mm Hg safety factor.
How does increased lymph flow help?
As excess fluid starts to filter into the interstitium, the lymphatics ramp up their pumping action, sometimes increasing flow 10-fold, 20-fold, even up to 50-fold. They actively drain away the excess fluid and return it to the blood, preventing the interstitial fluid volume and pressure from rising too much.
Okay, so the drainage system works overtime. What's the third factor?
The third is related to the lymph flow, the washdown of interstitial fluid protein. This also contributes about 7 mm Hg of safety.
Washdown. How does that work?
As filtration increases and lymph flow surges, the increased flow of fluid through the interstitium literally washes away the small amount of protein that normally resides there. The lymphatics are very effective at removing this protein. This process lowers the protein concentration in the interstitial fluid.
And lowering interstitial protein concentration reduces.
It reduces the interstitial fluid colloid osmotic pressure. Since if is a force that normally pulls fluid out of capillaries, reducing it makes the net filtration force smaller, thereby helping to prevent further fluid from accumulating in the interstitium.
Clever. So increased lymph flow not only removes fluid, but also removes the protein that would otherwise pull more fluid out.
Exactly. It's a double benefit.
So let's add up these safety factors. We have about 3 mm Hg from the low compliance negative pressure effect, about 7 mm Hg from increased lymph flow, and about 7 mm Hg from the protein washdown. That's a total of
Roughly 17 mm Hg.
a 17 mm Hg safety factor. What does that mean practically?
It means that the net forces driving fluid out of the capillaries, primarily capillary hydrostatic pressure, PC, would theoretically have to increase by about 17 mm Hg above the forces pulling fluid in before significant, obvious pitting edema would develop. Since normal capillary pressure is around 17-20 mm Hg, this means PC could almost double before you see major swelling.
That is a huge buffer. It really explains why we aren't all walking around with swollen ankles all the time. Serious edema really signifies that these powerful defenses have been overwhelmed.
Precisely. It indicates a substantial underlying disturbance in fluid dynamics.
Okay, one last related topic the source touches on. Fluid in the potential spaces. You mentioned these earlier, pleural cavity, pericardial cavity, etc.
Right. These are spaces where normally two membranes are almost in contact, separated only by a very thin lubricating film of fluid. Think of the space between the lungs and the chest wall, pleural space, or around the heart, pericardial space.
How does fluid exchange happen there?
The membranes lining these spaces act much like capillary membranes elsewhere. They're permeable to water, electrolytes, even small amounts of protein, which exchange with the interstitial fluid of the adjacent tissues. Fluid filters from nearby capillaries into both the surrounding interstitium and, to some extent, into the potential space itself. Essentially, these spaces behave like large, specialized interstitial spaces.
And do they have lymphatic drainage too?
Yes, that's critical. Lymphatic vessels drain excess fluid and, crucially, any leaked protein directly from these potential spaces, returning it to the circulation. This keeps the spaces normally almost empty, just moist.
So what happens when fluid does accumulate there?
When excess fluid collects in a potential space, it's called an effusion. This typically happens for the same reasons edema occurs in regular tissues. Either the adjacent tissues are severely edematous, spilling fluid into the space, or, more specifically, the lymphatic drainage from that particular space is blocked, perhaps by infection, inflammation, or tumor.
Like ascites in the abdominal peritoneal space.
Exactly. Ascites is a massive peritoneal effusion, but you can also get pleural effusions around the lungs, pericardial effusions around the heart, or joint effusions if there's generalized edema or a local problem impairing lymphatic drainage from that specific space.
And interestingly, the pressure in these spaces is normally negative too.
Yes, just like the interstitial fluid. The source gives values like -7 to -8 mm Hg in the pleural space, which helps keep the lungs expanded against the chest wall, and maybe -3 to -6 mm Hg in joint and pericardial spaces. This negative pressure is maintained by the lymphatic pumping action.
So even these specialized spaces follow the same basic principles of fluid exchange and lymphatic drainage.
Fundamentally, yes.
Okay, what a journey. We've really gone deep today into the body's amazing system for managing fluids. From the delicate balance of intake and output, the starkly different chemical worlds inside and outside our cells, how we actually measure these hidden fluid volumes, the sheer power of osmosis driving water shifts.
To the really serious clinical challenges like hyponatremia and hypernatremia, understanding why edema happens with all its diverse causes, and finally appreciating the body's incredibly robust safety factors that normally prevent it.
Yeah, this deep dive, using the GUYTON Hull material, hopefully gives you that foundational, really detailed understanding, the kind you need to think about these processes like the pros do. It's about seeing the connections, the forces, the regulation.
It's a beautifully complex and integrated system.
It truly is. And it leaves us with some things to think about, doesn't it? Like knowing about that huge 17 millimeter Hg safety factor against edema. What does it tell you about the severity of someone's heart failure or kidney disease when they do present with significant pitting edema? It means the underlying problem must be really profound to overwhelm such strong defenses.
Absolutely. It puts the clinical sign in perspective.
Or, flipping it around, how might understanding the specific mechanism causing someone's edema? Is it primarily low plasma protein? Or is it sky-high capillary pressure from heart failure? Or maybe a lymphatic blockage? How would pinpointing that cause completely change how you'd approach treating them?
You have to target the root cause, right? Just giving diuretics might not be the whole answer if the core problem is leaky capillaries or missing protein.
Exactly. Well, thank you for joining us on this deep dive into body fluid balance. We hope this exploration has given you a much richer appreciation for this vital, intricate, and often hidden system working constantly inside you.